opening till the mantle is one option. The second option is, some doctors what they do is, they see the metal foramen and they mark in pencil in the crest. So visually they don't have to go repeatedly see the metal foramen again and again. They see this pencil mark and they drill anterior to it. Okay. So using pencil to mark. And third is, even though you are placing implant number 4, slightly you are tilting mesially, slight mesial tilt to 10 degree. Okay, so tilting mesially. So all on 4 is actually, you are starting the implant from 5 and tilting mesially. All on 4 is tilting mesially from 5. But what we are doing is, we are starting from 4 only, slight 5 or 10 degree mesially. And fourth technique what I use is, select shorter implant, shorter length. Only if you go more deeper, the risk of touching the nerve. Select a shorter length. Okay. And fifth is orientation. Okay. So once you finish this interforamina area, then you can jump into the distal mandible. 6. Either you can put implant in the 5.5 no, but there is no 5 areas, maybe 5. Let's see. Mesial root, distal root of first molar, mesial root, distal root of 7, whatever. But here there is no tooth. Extracted, resolved. Okay. If it is extracted, heel area, what are the techniques? One technique is, there are two techniques. One is intramedullary placement. See, this is the mandible cross section, this is the nerve. Just place one implant like this. This is intramedullary, like a conventional. And other technique is lingual cortical engagement. So what is lingual cortical engagement? So the mandible is like this. You are placing implant like this. Okay. Of course, you should not go beyond like this. So, two techniques are used in the distal mandible. One is straight away, place a straight implant, but above the nerve. Okay. One more is not straight, tilted lingual cortical engagement. Intramedullary, where you can place when the nerve is very far away, you can do. If the nerve is like this, okay, at least 8 mm implant is the maximum short compressive length. For nerve safety, we need 1 or 2 mm. At least the length should be 10 mm from the crest to the canal. If 10 mm is not present, then you cannot place it intramedullary placement. Then you have to go for this technique. The nerve will be here. Okay. So either this one or either this one we can use. Okay. Now we will see. Now we will finish the interforaminal area first. See, this is not a straightforward. This is not a straightforward case. This is a resolved case. So I told you FMR you can divide into 2 categories. Easy, difficult, complex case. Easy, difficult, complex case is a complicated case only. Okay. So you will see that. You will see the interforaminal area. So this is canine, I guess, right? This is first premolar, this is second premolar. So I say in the second premolar it is Maxillofacial. Of course, they are not planning for anything in the second premolar. Now we are going to. This is first premolar. As I told, what is the shape? What is the crestal? Cortical. Crestal cortical is somewhat good, but anyway we are going to do a little dusting. Okay, you will be doing up to till here. but the bone is fully cancerous, not very good. But we have got enough width, enough length. If you use compressive implant, it will compress the bone and we will get stability. So definitely we will be using a wider diameter here, 4.2 into length maybe. Be around 13, 4.2 into 13 or something we can use. Okay. 360 degree you will see. Okay. So the 4 is a location 4 is a very ideal one. Diameter we get an idea, it is thick. So if you don't have CBCT, how will you decide about the diameter? Open and see it. Okay. Length, how will you decide without CBCT? Drill it and see it. Right, okay. Anyway, you are going to go till and feel the resistance here. Then you can decide, reduce to 2 mm, 3 mm, then do it. You are not going to perforate here. Okay. Never perforate the lower border. And lingually also, from premolar to premolar. So one implant is fixed, another implant in the lateral incisor. This next to canine. Anyhow, we are going to do capitoplasty here. See here, the buccal width is good, the intramedullary bone is also somewhat decent good. And if you place the implant head part will get support from the buccal and lingual cortical plate also, like similar to the last case. You will get good stability here. So another implant is fixed. This is the lateral on the left side. It is very similar to the right side. Now we will see the midline just for you can see the vessel, no? You can see the vessel going inside. It will go inside and it will make some anastomosis here. That is why don't do the drilling in the midline. If you can do, but if you stop the drilling till here, you can do. Only if you go very deep. So avoid midline. If you are doing midline, select a shorter length. Then this is the 4, right? You see here, this is 4, but the metal foramen is very close, and the root is slightly distally also angulated. So if you follow that, we may definitely injure. So what I was planning is slight. We will start from this crest. We will expose this. We will be making a mark here, and we will come here. Okay. So slight mesial tilt on the left side. So the interforamina planning is over. Now we are coming to the difficult part, the distal mandible. And one key important point is this bone. It goes, once we extract, this bone will be very sharp, like a mountain it will be. Okay, it will create problem during processes. So what you have to do is you have to flatten it. Okay, this part you have to remove. Okay, this part. This part you have to flatten. So this is our limit. Okay. So remove this triangular pyramid shaped bone. Then you can take it as a guide and you can remove. Almost till the root apex, even beyond the root apex, we may have to remove. Slowly this lower anteriors might have gone upward because of the injury. Now this may be the mesial root of 6, right? Now see the bone outline. This is the mesial root of 6. Crestal bone is thin, not very great, but fully cancerous, fully empty. There is nothing is there. Only some amount of bone is present. We can compress that. There should be something to compress. There is nothing here to compress. And another problem is When the bone is cancellous, one more problem comes. We cannot see the nerve properly. Even with CBCT, it is difficult to see where is the nerve because everything is dark and black. Okay. So one small guide is, this is a depression, right? The nerve may be above this. Okay. So this is the myroid ridge. This is the deepest point. So draw a line. The nerve mostly below this. Below this one. So the myroid ridge is starting in the mesial root of 6 as we go distally. This is somewhat more distal. Here the bone quality is better with the custom 5 mm. Of course here it is poor, but if you see the myroid ridge is more prominent but more upward. But I think able to see the canal. Where is it? Maybe this one, right? This one. So we will measure the length. The shortest length of compressive is 8 mm. Even if you place 8 mm, it is coming close to the nerve. Okay, so